Hello, and thank you for joining us for the webinar, Advancements in Breast Cancer Care. Before we get started, I want to cover a few items that relates to today's event. The presentation is being recorded. A link to the recording will be provided in a follow-up email. Part of the presentation contains graphic imagery related to surgical procedures, should anyone in attendance wish to look away from the screen during that time. If you have questions, please use the Q&A area to submit them. They will be addressed at the end of the presentation. Also, your feedback regarding today's presentation is very important to us. A link to a survey will be provided in the chat area if you can please take a moment to complete that at the end of the event. Today's presenters are Dr. Yarrow McConnell with Good Samaritan Regional Medical Center, or Good Samaritan Regional Medical Center Breast and Surgical Oncology, as well as Dr. Alexander Bagley with Good Samaritan Regional Medical Center Radiation Oncology. It is now my pleasure to turn this over to our presenters.
Thanks very much, Amanda. Dr. McConnell here. I'm going to present first, and Dr. Bagley's going to present second, and then we're both going to be able to answer questions at the end. So please put your questions into the Q&A as Amanda suggested, and we'll be addressing those at the end. First of all, Dr. Bagley and I, neither of us have any direct or indirect financial ties with any of the technologies, products, or companies discussed in this presentation. I'm going to be talking about two topics, genetic testing and oncoplastic techniques. These are topics that are part of our daily life in caring for breast cancer patients on the surgery side, and I think have really contributed most to changes and advancements in the surgical care of breast cancer patients over the last 5 years for sure, and even longer than that in reality. First, I'm going to talk about genetics as part of the breast cancer care pattern. Traditionally, we have thought that about 65% of all breast cancers are what are called sporadic cancers. So these are cancers that occur just simply because of aging tissues and mutations that happen naturally in our tissues over time, not related to any genetic predisposition or genetic changes that can be passed down from generation to generation. We've thought that about 10% or so of breast cancers are truly hereditary, meaning that they are caused by genetic mutations that are passed down from mom and dad to children and then result in cancers in those people later in their life. This third category, the familial cancers, we've not had a good explanation for why some cancers seem to run in families, but we can't find any genetic mutation for them. So I thought we should just keep these numbers in mind as we proceed through talking about breast cancer and our more current understanding of what these numbers likely are in reality. So until about 10 years ago, there were really only 2 genes that were thought to be related to breast cancer. These are very well known in most people's minds. BRCA1 and BRCA2 is how we refer to them. And we've known for some time that these lead to an increased rate of breast cancers and ovarian cancers in families where these genetic mutations are present and passed down through the generations. In more recent times, we've found that those 2 genetic mutation areas also contribute to pancreatic cancer in some families, to prostate cancer in some families, and with BRCA2 to skin cancer, and particularly melanoma in some families. We've also, most interestingly, I think, discovered that there are a lot of other genetic mutations that are present in some families, and that if you look on the left-hand side where the breast column is, that quite a number of these are related to higher risks of breast cancer. This is the current list, but every year there are new ones. So this is a rapidly evolving field. If we look at overall amongst breast cancer patients, and you look at that pie graph, and where are we balancing out in terms of these other mutations, we're finding that about 50% of breast cancer patients that we test for genetic mutations where they have a mutation found, about half of them are BRCA1 or BRCA2, and that the other half is this group of other genetic mutations. 3 of the most common, PALB2, CHEK2, and ATM, make up about 25%, and then a whole bunch of other ones that make up the other 20%. If we look at the different gene mutations in breast cancer along the bottom, you can see them, BRCA1, BRCA2, and then if you skip over to where PALB2 is, and then far to the right where CHEK2 is, you can see the blue line is what an average woman's risk is during her lifetime, and then the orange bars indicate how high is the risk of a breast cancer for a woman who carries one of these genetic mutations out to the age of 70. So in a BRCA1 carrying patient, her risk of having a breast cancer before the age of 70 is somewhere between 50 and 85%. If you look at PALB2, her risk is somewhere between 10% and 50%. And for CHEK2, it's somewhere between 20 and 30%. So for these 3 different women with 3 different mutations, their risk is very different. They are all at high risk. They're all higher than the average risk, but very different in terms of their overall outlook on their life and how they might want to manage their breast cancer risk over time, both in terms of screening and prevention. So in terms of what has this done for surgery, this understanding of variable risk with different mutations means that when we sit down with a woman to counsel her about and talk with her about what kinds of things could we do to prevent breast cancer for her, that discussion has to be in the context of what is her real risk based on her mutation. But in all cases, the data suggests that by doing mastectomies, removing both breasts, whatever her baseline risk is, we can reduce that by about 90% by doing mastectomies. So for instance, in the PALB2 patient who had about a 50% risk maximally of getting breast cancer, we can reduce that to about 5% or so. If we were to do oophorectomies as well, so removing her ovaries, we can reduce that risk as well. That's a lesser degree of a reduction than the mastectomies, but still substantial. And then the third mechanism we use for reducing risk is by using medications. The column in the middle represents some data for tamoxifen, which is an anti-estrogen medication that's given daily for 5 years. And it can reduce the risk of a second cancer in a woman who's already had a cancer. There's emerging data that it might also be useful in women who've never had a cancer to prevent cancer in these kind of ladies who are not yet ready to have surgery, but who want to do something to reduce their risk. But obviously the biggest risk reduction comes from doing mastectomies. And this has really changed our practice in the breast surgical domain, because we are seeing more and more of these patients who want to talk about whether or not mastectomies are the right choice for them. This is the data from Samaritan Health Services from January to June of this year. We tested 146 patients for that broad range of genetic mutations that you saw on the previous slide. We found 16 mutations amongst those tested patients out of 106 who were tested with a diagnosis of breast cancer. That's higher than that 10%. So I think we're starting to find that some of that familial risk from that original slide I showed you is in fact a genetic risk. It's just at a lower risk level, and it's in genes that we're only just starting to find out about. And so I think over time, that genetic risk portion of that pie chart in the beginning is going to get bigger and bigger and bigger, and it's going to expand into that familial risk group as we start to explain more and more of these family histories. I'm now going to talk about the second item on my list, which is oncoplastics. And this is a whole field of study and of techniques that surgeons have developed over the last 10 to 20 years. And really what it's about is helping women to move from a place where a lumpectomy is a disfiguring operation to one where we can really work in a nicely contoured breast and breast symmetry into the plan of care for their breast cancer, so that the long-term implications for all these women who are living long lives after breast cancer is that their breast is healthy, but also comfortable. What is oncoplastic breast surgery? So basically what happened was you had a bunch of surgeons who were breast cancer surgeons doing lumpectomy, and you had a bunch of surgeons who are plastic surgeons doing breast reconstruction. And these two worlds started to come together more and more, and we weren't just taking care of patients who were having a mastectomy and then an implant. We started to take care of patients together where we were doing a lumpectomy and then wanting to move around tissue inside the healthy breast to fill that space where we had removed the cancer and the surrounding tissue. The techniques are there. There's whole books written about this now, big, thick textbooks written about this now. So I'm not going to go into all the technical details. Just wanted to sort of explain the concept for you. And then I'm going to show you a couple of case studies so that you get to see a little bit about what I'm talking about in terms of what kinds of things we can do with the breast tissue to create a healthy, comfortable breast for women after cancer surgery. So on your left, you see a series of diagrams. These are plastic surgery techniques. You can see the top one, what's called a donut mastopexy. So basically you take some skin around the areola and then cinch it in and sew it to the edge of the areola so that you sort of tighten up the skin envelope of the breast. Below that, you have two approaches. One's called the keyhole and the other's called the anchor. And these are ways to do breast reductions, where you're removing both tissue and skin, and then bringing the breast tissue together and bringing the skin together in the scar patterns that you can see on to the right of those two, where the scars are hidden at the bottom part of the breast. So us breast surgeons, cancer surgeons, we're worried about taking out the tumor and a nice big envelope of tissue around it, but then we started using these techniques for closing the tissue. You can see an example on the right using a keyhole approach. The tumor is in yellow there. Remove that bottom breast tissue, move the nipple and areola up a bit, and then bring the skin together to close around that. And that brings the tissue from the middle part of the breast and the outer part of the breast together in the middle to fill in that space where the lumpectomy specimen came out of. And then we went a step further and we started rotating this around the breast, which the plastic surgeons had never had to do because they didn't have to think about tumors, and started orienting that solution in different parts of the breast to deal with tumors in different locations. So I hope this sort of gets your brain going in terms of the flexibility that these techniques give us, but also how we've had to sort of step outside of our comfort zone to adopt these techniques and then start moving them forward with tumors in all different portions of the breast and in all different sizes and shapes of breast. So this is where I'm going to show some pictures. So if pictures are difficult for you to look at, I invite you to just look away or minimize the screen. You can still listen to me talk while we go through these slides. Oh, before I do that, one more slide, apologize. This is just to highlight that in the last 10 years, there's also been a lot of data around oncoplastics, many studies done and published. And we now can confidently say that because we're able to take out generous amounts of tissue and get wider margins, because we now know we're able to move tissue in and close that space, we are seeing a lower margin positive rate. We're seeing local and regional recurrence rates declining a little bit because of this. We're seeing similar post-op complication rates in centers where they're doing a lot of this kind of work, like at our center. Seroma, hematoma, and infection rates are pretty similar between traditional lumpectomy and oncoplastic lumpectomy. And most importantly, studies that are looking at the satisfaction rate amongst women with the comfort, appearance, and symmetry of their breasts after radiation at that 6-month point are seeing that women are more satisfied after an oncoplastic approach than after traditional lumpectomy when you compare like patients to like patients. Here we go with the graphic content. So this lady, oh, and I will say that all of these patients are patients of mine, surgery that I've performed, and all of them provided written consent for me to use their pictures. And they were actually really happy that we were going to be talking about these things and spreading the information to women and professionals around the community. So I'm really thankful to them for having provided us with these pictures. There are no faces in any of the pictures. So this lady had a tumor in her upper right breast, as you can see by the little box that I've drawn on her breast. Traditionally, we would have done a lumpectomy by making an incision right over top of that, going straight in through the skin, removing the cancer and a margin of tissue, and then closing the skin and closing the tissue underneath, sort of top to bottom, pulling up the bottom part with some sutures, and then closing the skin with some sutures. We would have then had an experience with a woman over time of the weight of the breast pulling on that skin, creating stretching and creating some divot in the tissue so that you can actually feel where the tumor was removed. And that is what we avoid by doing this kind of approach. So you can see where I've marked around her areola with a crescent moon. And that's the plan for the surgery. Make an incision there, take out that little crescent of skin, go up underneath the skin, remove the tumor, and then pull the tissue up from below and from the middle and the lateral parts of the breast, so 3 directions, and then bring the tissue together underneath. And then as you pull the skin closed and bring that nipple up a little higher, it brings up the weight of the breast and allows the tissue to heal more in that upper position so that you don't get that divot formation and that you have a contour to the breast that gets maintained over time. So when we do that, you get this kind of appearance to the breast post-op. So you can see her bruising pattern, which is pretty standard. She's probably about 10 days after surgery. And you can see her nipple is a bit higher and the incision around the upper breast above the areola, that's her scar. And some women would be very happy with this and would not be concerned about any asymmetry between the two breasts. This woman was very concerned about being asymmetrical. And so we, at the same time as we did her breast surgery, we did a little lift in the other breast in order to match them left to right and to keep those nipples at the same level. So this is the kind of approach that we're talking about in terms of pretty straightforward, almost everyday kind of oncoplastics. So this would be a weekly kind of surgery that we would do. This lady was a lady who had a tumor down in the bottom part of her breast. Again, I approached it through this incision around her areola. I had to take some skin at the bottom side in order to remove that tumor fully. She was not so concerned about symmetry, and so we decided to go ahead and do this breast surgery first, and then only to decide later whether or not she wanted anything done on the other side. So this was her result, and this is actually after radiation. You can see that she's got a little bit of dimpling down at the bottom of her breast. But in general, she was very happy with the symmetry, and she decided not to have any surgery on the other breast. So I don't want anybody going away with the impression that you always have to have surgery on the other side. Definitely not true. And lots of women now in my practice, we do the one side and then wait and see whether or not she wants to have anything done on the other side. This lady is in a different category. She had quite a large area of tumor. This is her picture on the day of her surgery. Her tumor is over here in the outer side of her left breast, and she has a number of what are called localizing wires in there to help me do the surgery. The markings that I've made on her chest on both breasts are what are called traditional reduction markings. So these are what a plastic surgeon would do to do a breast reduction. But I'm going to do her surgery for her tumor using a reduction approach. It's just that the tissue I'm going to take out to do the reduction is her tumor tissue with a good generous margin around it. in the operating room, so this is with her asleep on the table. This left breast is sort of halfway done, meaning that we've done the tumor removal, we've rearranged the breast tissue, and I've got little metal clips there to put the skin in place so that I can sort of see what the shape's looking like and how we're going to do the other side to match it, but I haven't done all the suturing yet. So we're not at our final stage. You can see that this breast now looks quite different from this one. At the end of the operation, this is how things stood. So now everything is sewn up in that anchor type incision on this side, and this breast has now been reduced and lifted to match this one. The steri strips are on, all the stitches are underneath the skin. So that's probably the most complex type of operation that I would do myself. This next lady had the need for both my skills and also the skills of a plastic surgeon. So sometimes we do these operations in combination with a plastic surgeon. This lady obviously was very large breasted. She had breastfed many children, and now she had a large tumor in her breast here in the middle part of her right breast. She had to have some chemotherapy before surgery. And then when we came to her surgery day, I planned to do this in combination with a plastic surgeon, so 2 teams. I removed this large piece of tissue here on her middle breast. We reduced the size of her areola, and then we lifted it up and used this healthy tissue out here to recreate a smaller breast. And at the same time, the plastic surgeon was working on this breast to do a more traditional reduction, but to match it. And so her final result, she was very happy with this, both in terms of being cancer-free. She still had her port in for in case she needed chemotherapy after surgery, but she didn't end up needing any, so that was removed a little while later. She'd had her radiation to this right breast and been able to maintain the contour and the symmetry pretty well, and she was very happy to be smaller breasted. But most importantly, that tumor has been fully treated, and she has a very, very good chance of being cancer-free for the rest of her life. So that's the end of my presentation. I'm going to hand it over to Dr. Bagley. But before I do, I just wanted to say that the treatment of these women is a multi-disciplinary and requires a lot of people. Dr. Bagley and I work together, but we also work with large teams of people to make all this possible for women. So I just wanted to thank my whole team. I think some of them are online here today. The PAs, my partner, Dr. Shirley, our nurse navigator, Julie, and the whole team that goes into that's required to make all this happen for women. Dr. Bagley, take it away.
Thank you. And thanks everyone for having me. I'm just going to share my screen here. So I am one of the radiation oncologists at Good Samaritan, along with Dr. Norman Ye and Dr. Patty McGowan. And we often see patients after they've undergone breast conserving surgery, and we talk to them about different radiation options. The options for radiation that we discuss with patients range from treatment of the whole breast, typically over a 3 to 4 week course of radiation, to treatment of just a portion of the breast, a technique called partial breast radiation. And then for patients who are felt to be at the lowest risk, we will also discuss the possibility of omitting radiation altogether. And so I'd like to go through 3 sample cases today to kind of illustrate how we help patients think about these different options. So the first example case is a 48-year-old woman who is diagnosed with invasive ductal cancer of the left breast, who undergoes a lumpectomy followed by a sentinel node biopsy, and the final pathology returns as a 25 millimeter tumor that is estrogen receptor positive and HER2 negative. It's a grade 2 or intermediate grade. It has a negative margin, but close at 1 millimeter, and 0 out of 2 sentinel nodes are involved. And so this patient is referred to our clinic in radiation oncology. And with any patient that comes into the clinic, we review their clinical history with them. We go over their imaging and pathology results in detail. And some of the specific things that we are focused on with regard to their medical history are if they've had any prior radiation treatments, any prior cancer diagnoses, if they have any autoimmune disorders or connective tissue disorders such as lupus or scleroderma, which might make the skin or soft tissues more sensitive to the effects of radiation. And we also inquire if they have medical devices like a pacemaker. Social history is also a very important part of our initial evaluation of patients. We want to make sure that every patient has the necessary support that they need. And also transportation can be an issue because some of these treatments might require coming into our clinic every day for a month. And we have an Office of Social Work that is very involved in helping patients with address these needs. And I think working out these issues in advance really does help our patients get optimal care. So for this first case, a 48-year-old woman with a 25-millimeter tumor and a close but technically negative margin. This is a patient we would think about recommending whole breast irradiation. Whole breast irradiation is currently the standard of care for invasive breast cancer after breast conserving surgery. It typically involves treatment of the whole breast over 15 to 16 daily treatments. And we also talk to patients about a tumor bed boost for an additional 5 treatments. This involves giving an extra dose of radiation around where the tumor was initially located, with the thought being this is the area that's at greatest risk for future recurrence. Any patient who's 50 years or younger with any grade disease will consider for a tumor bed boost. Patients 51 to 70 with high-grade disease or those with positive margins are strongly recommended to consider a boost, but we'll also talk about this with other patients as well. I just wanted to make a comment here about a technical advance that our clinic uses and many others around the country use, which is called the deep inspiration breath hold technique, or DIBH. When a person takes a deep breath, it shifts the position of the heart within the chest cavity, and it typically moves the heart down and away from where the radiation is being delivered. This is particularly important for left-sided breast cancers where the heart sits on the left side of the chest. We can do this technique and it leads to a significant reduction in the radiation exposure to the heart and also to the lungs. And so for the vast majority of our patients with left-sided breast cancers, we will discuss this option with them. And I think it does help reduce long-term toxicity. This is the data that has shown the benefit of adding radiation to breast conserving surgery. The graph on the left shows the percentage of any first recurrence of breast cancer out to 10 years on this graph. And you can see with surgery alone in this large study, the rate of recurrence was reduced by about half when radiation was added to surgery. And this led to a small but significant increase in survival. We talk to all patients about the potential side effects of radiation therapy, and I like to divide them into the early and short-term side effects, the most common of which are shown in bold here, which are fatigue, skin redness, darkening, itching, soreness, and breast swelling. And then the late or long-term toxicities, which may develop months or even years after radiation is completed, the most common being a change to the breast and skin appearance in terms of the size, shape, color, and texture. There are some more rare side effects which are shown below. One that I'll just comment on is lymphedema. For early stage breast cancers where we're not routinely treating the axillary lymph nodes, we don't think that radiation adds a significant risk for lymphedema, but certainly for more advanced breast cancer patients or those who have had a more extensive surgical dissection, lymphedema is an important long-term risk. And our center has a very fantastic lymphedema clinic that sees many of our patients and helps them work through with any therapy, exercises, and other equipment that's needed to help reduce that risk. So now I'd like to turn to the second case, which would be a 75-year-old woman with invasive ductal cancer of the right breast who undergoes a lumpectomy and a sentinel node biopsy. And the pathology returns as a 4 mm tumor. So this is much smaller than the first case. It's estrogen receptor positive, HER2 negative. And there's a marker that we look at called Ki67, which is a marker of how quickly the cells are proliferating or dividing on a scale of 0 to 100%, where 100% would be the most aggressive. So 2% means this is a fairly slow growing tumor. It's grade 1 or low grade. There's a negative margin and no lymph nodes were involved. And in talking with the patient, they stated that they plan to take endocrine therapy after surgery. So when we look at this constellation of findings, the age, the small size of the tumor, the estrogen receptor positivity, negative margins, no involved nodes, planning to take endocrine therapy, this would be a patient that we would talk about omission of radiation as one of several options. You can see that we would consider this for patients typically 65 to 70 and older who have ER positive and negative margins, negative nodes, and they're willing to take endocrine therapy. This is one of the well-known studies that has led to this recommendation. Here you can see a graph showing the percentage of patients who are surviving without a recurrence. And you can see that while the addition of radiation, shown as RT here, does lead to a significant improvement compared to endocrine therapy alone, 98% versus 90%, this study in women who are 70 and older found no difference in overall survival with the addition of radiation. So this particular patient would be a reasonable candidate for omission of radiation. Additional questions that are being looked at now is, can radiation be omitted in younger patients? There was a recent study called the Lumina trial, which looked at women 55 and older. This had relatively short follow-up, but did show some promising results with endocrine therapy alone. And then a related question is, can endocrine therapy be omitted after radiation? There is a trial ongoing in Europe which is comparing endocrine therapy versus partial breast irradiation. I believe this is in women 70 and older with early stage luminal A breast cancers. And I think the results of these will help us figure out which patients we can safely de-escalate treatment while maintaining the high rates of local control that have been achieved over the last several decades. And the final case I'll present is a 60-year-old woman with invasive ductal cancer of the right breast who has lumpectomy and a sentinel node biopsy. The tumor comes back as 10 millimeters, that's about the size of a pea. Estrogen receptor positive, grade 1, negative margins, and 0 of 2 sentinel nodes involved. So this patient has kind of somewhere in between the two cases that I discussed earlier. And so this is a patient we would think about partial breast irradiation. And we consider this for patients who are 50 and older, who have tumors that are 2 centimeters or smaller, that are ER positive, negative margins, and no lymphovascular invasion or LVI. We will consider this for other patients as well on a case-by-case basis, and that really is involved in the discussion with every patient. Accelerated partial breast irradiation, or APBI, was shown in a trial that was also done in Europe to have similar rates of recurrence compared to whole breast irradiation, as you can see in this graph here, where the rates of recurrence in the ipsilateral breast, or the same side that the cancer was initially, are very low in both groups. In addition, in this trial, partial breast irradiation was associated with improved cosmetic outcomes as judged by both patients and physicians long term, and part of that may be due to treating less of the normal breast tissue as opposed to whole breast irradiation. And so from this trial and several others, there are several different regimens that are available to do partial breast irradiation. The preferred option is the one in the trial that I just mentioned, which is given in 5 treatments total, and QOD means every other day. And this is the preferred option by the current NCCN guidelines. So in conclusion, radiation plays a very important role in the management of early stage invasive breast cancer. There are multiple radiation approaches that we use to help individualize care for our patients, ranging from whole breast irradiation with or without a boost to the tumor bed, partial breast irradiation, or omission of radiation. And technical advancements in modern radiation therapy, such as the deep inspiratory breath hold approach, have the ability to reduce toxicity and the risk for long-term effects. I think we can now take some questions if there are any from the group. Thank you.
Thank you both, Dr. Bagley and Dr. McConnell. There is a question out there. Can you share what role the patient plays in determining treatment decisions?
I can speak to that from a surgical perspective, and then I'll turn it over to Dr. Bagley to speak about the radiation perspective. The approach that breast surgeons take to that discussion with women is very nuanced, and I think there's a lot of things that come into play when we make decisions with women, but I do want to emphasize that word with. The woman's input in terms of her breast tissue management options, her concern about future recurrences, and her family history all play into the decision. And so I would say that for the most part, women have a great deal of input into their surgical decision making. And I think that's very appropriate because we do have so many options, and I think in many cases, there's no absolutely right or wrong, black and white answer for every woman. Very occasionally, I meet a woman who is in a very difficult situation where she has an advanced or very aggressive cancer, and we have to have a discussion about a mastectomy or something that I really strongly feel is her only option. And in most of those cases, she usually knew that even before I said it to her. But for most women, there's a lot of detailed discussion around all the different options and how to work their way through that decision-making process. Sometimes there's so many that it can be a bit overwhelming for women. So many decisions, so many options. And so part of our role is to help them work through that decision-making process, making sure that they remain true to themselves and what they want out of the process, but also making sure that we've treated their cancer and that they know we're not letting them do anything that isn't in their best interests. And so number one is treating the cancer, and number two is making sure the woman's going to be comfortable with to live with for the rest of her life. Dr. Bagley, anything to add?
I would echo everything that you just said there. I think when we see patients, it's extremely important to me and to my colleagues to make sure that the patient's goals of care are clearly known in the initial consult. And I think when you're dealing with an early stage breast cancer where many of these are curable, we need to think carefully about the balance between cancer control and then the toxicities of the treatment. And what I have found in my practice is that patients have very different feelings about these and how they weigh those in their mind. So for me, it's really important to get a sense of that in the initial consultation to help find the treatment that is best for them.
Thank you so much. I'm going to go ahead and ask the next question. And for patients with travel concerns or who have elongated treatment plans, which both of you touched on that, how are you able to accommodate them?
I can answer that one. So, we have many patients coming from the coast, and so they may be commuting 1 or more hours to come in for treatments. So that can impose a significant burden on a lot of patients. We do have the Mario Pastega House, which is on the campus, and a lot of patients from out of town will stay there at least part, if not all of the week during treatment and then go home on the weekends. I think that can be a good option for patients who are considering longer treatment courses.
Thank you so much, Dr. Bagley. And then what do you both see as be next for breast cancer treatment as it continues to evolve?
I can take that one initially. The treatment of breast cancer is becoming much, 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 much more complex. And I think any woman who's been through treatment recently will attest to that. But I think that although that trend will continue and will continue to struggle with keeping everything coordinated and needing a team of people to take care of breast cancer patients, I think at the end of the day, it is making it better. We're not just putting all women with breast cancer into one box and treating them with an algorithm. We now know enough about all the various different types of breast cancer, genetics that are different, different changes that happen within the tumor, responsiveness to chemotherapy. All these factors are playing into us having to develop a treatment plan for women that is for each woman that is very much targeted at their breast cancer, their family history, their personal history, all those factors. But at the end of the day, getting better results in terms of more women surviving, more women living without ever having their breast cancer come back, and more women living with a comfortable chest, going back to doing all their normal activities and living out full, productive, and comfortable lives. So I think the complexity and the need for specialized teams to take care of patients is the biggest thing that I see happening and that will continue to happen.
I think from a radiation perspective, if you think about the evolution of radiation for breast cancer over the last several decades, when it was initially given, it was given over 5 to 6 weeks of daily treatment. And I think the trend over time has been to reduce the number of treatments as well as the volume of tissue that's being irradiated. So I think, that's really the larger trend, is kind of de-escalating the size and number of treatments for radiation. And I agree with Dr. McConnell that it is becoming more complex because when you factor in the molecular profiling of the tumors and the genetic alterations, what we're learning is that, 2 breast cancers that previously we would have treated similarly now may be needing to be managed differently because of the molecular differences between them. And so I think that really is where the future is going, is integrating genomic testing. There are tests that we use routinely in our practice called the Oncotype test and others that help us assess risk for recurrence. And I think that plays an important role and will continue to in the future.
I just want to speak to one other factor that I thought about while Dr. Bagley was talking, and just thinking about the fact that radiation, we're starting to move towards fewer fractions in some women, shorter courses. And at the same time in breast surgery, there is sort of 2 divergent paths. In some women, we're able to do smaller and smaller surgery, making it less and less impact on the breast. But in other women, for many different types of reasons, some genetic, some in terms of wanting to avoid radiation altogether or avoid traveling long distances, we're actually in some cases doing a mastectomy where prior we wouldn't. So it's going in both directions, but very much driven by data around an increased understanding of these breast tumors and an increased understanding that women need to be able to make these choices for themselves so that it best suits the rest of their lives.
We've had a couple more questions come through the chat. This one looks like it's for you, Dr. McConnell. There's a lot of hard work spent in helping women have a lumpectomy to create an aesthetic post-surgical appearance. But why isn't more attention spent in helping women receive an aesthetic appearance post-mastectomy when reconstruction is not desired, such as minimizing dog ears?
Thanks for that question. I focused today on the lumpectomy population and the women who have that type of surgery. I didn't touch on the mastectomy population, and I think you're drawing attention to that, rightly so. The techniques that we use for minimizing extra skin and extra fatty tissue, it's a horrible name for it, but it is called dog ears, out at the sides of the breasts with that fatty tissue that we all have at a certain point in our life out under the arms. And there are advances in that. Those techniques are not yet, I would say, widely disseminated, and neither are these oncoplastic techniques for lumpectomy. These things are being done in specialized centers, and we're getting better and better at them, but nobody's perfect. And those little annoying dog ears under there after mastectomies continue to be an annoyance for patients, and we do our best to eliminate them. But sometimes they do require second procedures or additional attention to get them so they're comfortable and they don't rub. But I hear you. It certainly is still an issue that we need to address.
And it looks like we have another question. Can you talk about the breast cancer index and what is the test and what does it tell us?
So I think we'll probably need some clarification of the question. Because I'm not sure what index we're talking about.
Okay. It doesn't look like there's more in there. The person who asked it, if you're able to elaborate in the Q&A area, then we can circle back on that one. Otherwise, we
Dr.
are.
Bagley talked about the Ki-67 index. We have the Oncotype DX. There's a number of different indexes, so just to be clear so we can answer for you, that would be great.
To expand on that question, the test done at 5 years to determine further use of Yarrow, I'm not going to pronounce
aromatase inhibitors.
Thank you, yes.
I think you're asking a question about that we would need a medical oncologist to answer for you. I'm not familiar with any testing at the end of 5 years to determine further use of aromatase inhibitors, but that's probably just a blind spot in my knowledge base. Dr. Bagley, are you able to answer that?
No, I think a medical oncologist would be the best to address that. Yeah.
This is what specialized medicine is about. You get two specialists in their own areas, and and we can't answer a good question. Sorry about that.
That's okay. We could certainly circle back with the individual who's asked it. Well, we have gone through the questions that have been asked. Thank you, both Dr. Bagley and Dr. McConnell, for your time today, as well as everybody who's been able to join us. Again, your feedback is very valued. I have placed the link to the survey within the chat area. If you could take a moment to fill out the quick survey, it's very brief. It will also be provided in the post-event email that has the recording to the event today, as well as that survey link again. And for future webinars offered by Samaritan, you can visit samhealth.org/behealthy. Otherwise, thank you again and have a great day, everybody.